Let's dive right into the dark mode clinical logic for breast pathology and presentations for USMLE Step 2 CK. Breast complaints make up a massive chunk of ambulatory medicine questions, so we really need to rapidly synthesize chronologies, mechanisms, presentations, and preferred tests. The goal? Answering these questions in under 60 seconds. We're looking at this strictly through the lens of a third-year medical student facing the boards. Let's get to it.
First up, patient context triage. We're looking at age under 30 versus 30 and older, whether they're pregnant or lactating, cyclic versus non-cyclic pain, unilateral versus bilateral discharge, spontaneous versus expressed, bloody versus milky, focal mass versus diffuse nodularity, and any fever, fluctuance, or concerning skin changes. You absolutely have to establish this context the second you read a presentation to figure out the right pathway. It's like finding those key forks in the road. Is the patient under 30? Are they pregnant? Is the pain cyclic? Every single one of these factors drastically shifts your next best step in management. Seeing a fever and fluctuance, for example, boom, you immediately shift away from an oncology workup and straight into abscess management.
Now, for a palpable breast mass, your initial workup sequence is strictly age-based. If your patient is under 30, an ultrasound is going to be your first-line imaging. Why? Well, younger breast tissue is very dense, which makes mammograms incredibly difficult to interpret and highly prone to false negatives. But if the patient is 30 or older, a mammogram, with or without an ultrasound, is your starting point because older breast tissue has more fat, giving us much better radiographic contrast. From there, the imaging dictates if you're dealing with a simple cyst, a complex mass, or something highly suspicious. Okay. Here is an absolutely crucial rule for clinical suspicion. Regardless of imaging findings, a highly suspicious physical exam mandates a core biopsy, even if the imaging looks totally reassuring. If a question stem describes a 55-year-old with a firm, fixed mass, but her mammogram is read as normal, do not reassure her. Now, fine needle aspiration is an appropriate initial technique for cysts, but it can easily miss a solid malignancy because it has such low sensitivity and lacks tissue architecture. Persistent clinical suspicion always requires definitive tissue diagnosis via core biopsy. So what happens when imaging reveals a simple cyst on ultrasound? Well, your next step depends entirely on their symptoms. If the patient is completely asymptomatic, you simply observe. No need to intervene, just reassure them. However, if that simple cyst is tender, expanding, and causing discomfort, you can perform a fine needle aspiration right then and there for immediate symptom relief. Knowing exactly what to do after the aspiration is where you're going to win those test points. Let's contrast simple cyst follow-up scenarios. A clear aspirate with mass resolution just requires a repeat breast exam in 2 to 4 months, versus a bloody aspirate, persistent mass, or complex cyst, which demands an immediate biopsy and additional imaging. If you draw out clear fluid and the mass completely resolves, your job isn't completely done, You still need to repeat that exam in a few months because cystic fluid can reaccumulate. But if that aspirate is bloody, or the mass just won't go away, or the ultrasound showed a complex cyst with septations right from the get-go, you immediately pivot to biopsy and additional imaging. No questions asked. Shifting gears from palpable masses, what about patients presenting purely with breast pain? Here, cyclicity and focal features dictate whether you just observe or proceed to targeted imaging. If the pain is cyclic, bilateral, and diffuse with absolutely no mass, you just recommend a supportive bra, NSAIDs, and observation. But if the pain is non-cyclic, unilateral, and focal, even without a palpable mass, targeted imaging is absolutely required just to make sure nothing insidious is hiding in that specific localized area. You really want to master this benign breast disease comparison grid. First up, fibrocystic changes. These present as multiple, bilateral, diffuse nodulocystic masses with cyclic tenderness. Management, supportive bra, NSAIDs, and reassessment after menses. Next is fibroadenoma. This is a solitary, mobile, well-circumscribed mass that's estrogen responsive, typically in patients under 30. For adolescents, you can just observe, but you'll want an ultrasound for persistent masses or older patients. Finally, fat necrosis. This usually pops up post-trauma or surgery as a firm, irregular mass. You just excise the mass and reassure the patient. If the exam hits you with a 22-year-old who has a rubbery, mobile mass, you should instantly be thinking fibroadenoma.
And beware the ultimate mimic here, fat necrosis. As we see here, fat necrosis can present with calcifications on mammography and a fixed irregular mass on physical exam, strongly mimicking breast cancer. It usually follows blunt chest trauma or a recent breast reduction surgery. Because it looks, feels, and images so much like cancer, the appropriate step is to excise the mass and reassure the patient once pathology actually confirms it's simply necrotic fat and foamy macrophages.
Another classic benign presentation is the intraductal papilloma. It's characterized by unilateral bloody nipple discharge without an associated mass or lymphadenopathy. This is a benign tumor arising from the breast duct lining, but it famously presents with that scary unilateral spontaneous bloody discharge. The key discriminator to remember here is the total absence of a palpable breast mass or axillary lymphadenopathy. If the question stem describes bloody spots on a patient's bra, but her clinical breast exam is completely normal, intraductal papilloma is your answer for sure. Management usually requires mammography, ultrasound, and biopsy, often with excision, just to confirm its benign papillary nature.
Okay, transitioning over to malignancies now. It's super important to connect breast cancer warning signs directly to their local pathophysiology so you aren't just memorizing raw lists. A fixed breast mass happens because the tumor has directly invaded into the adjacent breast tissue or the pectoral fascia. Nipple retraction? That occurs when the tumor invades the lactoferous ducts, literally pulling the nipple inward. And nipple scaling or ulceration strongly suggest epidermal infiltration by neoplastic cells, which is classically seen in Paget's disease of the breast. You absolutely must be able to differentiate these high-yield clues perfectly. Skin dimpling is caused by tumor invasion of the suspensory Cooper ligaments, versus peau d'orange, which is caused by obstruction of the dermal lymphatics. Dimpling points specifically to the tumor invading and retracting those Cooper ligaments, creating this localized tethering. In contrast, a peau d'orange, or orange peel appearance of the skin, means the tumor has obstructed the dermal lymphatics, causing severe local edema and swelling right around the hair follicles. You'll see this lymphatic obstruction classically in inflammatory breast cancer. And importantly, that presents with warmth and erythema, but it completely lacks the systemic fever you'd see in an infectious mastitis. Let's look at modifiable and non-modifiable breast cancer risk factors. You really need to separate modifiable factors, like hormone replacement therapy and alcohol consumption, which, by the way, is a heavily tested dose-dependent risk factor, from the non-modifiable risks. The most common risk factor overall is literally just increasing age, simply due to the higher probability of spontaneous genetic mutations over time. Other non-modifiable risks include a family history in first-degree relatives, white race, early menarche, and late menopause. Nulliparity and increased age at first live birth are also huge factors because they prolong the unbroken span of menstrual cycles. The overarching principle tying so many of these risk factors together is that breast cancer risk is directly correlated with lifetime exposure to estrogen. The more menstrual cycles a woman has in her life without the anovulatory break of pregnancy, the higher the continuous estrogenic stimulation on her breast tissue, and thus the higher the risk. This directly dictates aggressive screening protocols. High-risk patients, such as those with BRCA mutations, may require an annual breast MRI right alongside standard screening, because standard mammography just isn't sensitive enough for their risk bracket.
Shifting gears to a highly testable chief complaint, nipple discharge. Use these specific pairs to instantly triage nipple discharge on your exams. Physiologic nipple discharge is bilateral, multiductal, and expressed only with manipulation, versus pathologic nipple discharge, which is spontaneous, unilateral, bloody, or associated with a mass. So, if a patient says, "I only have discharge when I squeeze my breasts," the exam is pushing you toward a physiologic, benign cause. It requires squeezing, it comes from multiple ducts, and it happens on both sides. But if it happens spontaneously on its own, comes out of only one breast, has blood in it, or is accompanied by a lump, it is definitively pathologic and needs a full workup.
Pathologic discharge triggers an immediate age-based imaging pathway. The cutoffs are pretty similar to a palpable mass. Under 30 gets an ultrasound to evaluate the ducts. 30 to 39 gets a mammogram with or without an ultrasound, and 40 and over gets both modalities simultaneously. Now, here's the kicker. If that initial imaging for pathologic discharge comes back completely negative, you are not done. A breast MRI is indicated for further evaluation to go find that occult source of the bleeding. Conversely, if the discharge is physiologic and milky, you're looking at a Galactaria endocrine workup panel. You'll sequentially evaluate for hyperprolactinemia, which is the most common physiologic cause. Run a pregnancy test, check prolactin levels, get a TSH to check for hypothyroidism, consider a pituitary MRI for an adenoma, and review medications like antipsychotics or metoclopramide. Always get a pregnancy test first. Check TSH because primary hypothyroidism drives up TRH, which actually stimulates prolactin release. And definitely don't forget to review the patient's meds, especially dopamine antagonists like risperidone or metoclopramide, because dopamine tonically inhibits prolactin. Take away the dopamine and prolactin levels spike.
Let's wrap up by navigating the postpartum lactation complications, looking at this chronologically. A poor latch causes nipple injury, think abrasions, cracking, and pain between feeds. Engorgement typically hits 3 to 5 days postpartum, presenting as bilateral breast fullness when colostrum is rapidly replaced by high-volume mature milk. A plug duct presents as focal tenderness without a fever, and a galactocele is a subareolar mobile, well-circumscribed mass, also without a fever. Crucially, notice that all of these initial complications present completely without a systemic fever.
You have to be able to distinguish mastitis from an abscess by the physical exam. Mastitis gives you focal tender erythema plus a fever, and it's treated with analgesia, continued breastfeeding, and antibiotics. A breast abscess, on the other hand, adds a fluctuant mass to the mix, and that requires an ultrasound, drainage, and antibiotics. With mastitis, you absolutely instruct the patient to keep breastfeeding or pumping. Emptying the breast is so critical for clearing that stagnant fluid. But if you feel a fluctuant, palpable mass, it's progressed to an abscess. That immediately shifts the management to include an ultrasound for confirmation, followed by incision and drainage along with those systemic antibiotics.
Finally, we have nipple candidiasis. This presents as bilateral, shiny, painful nipples in a breastfeeding patient, often with severe shooting pain during or after feeds. It's an intense, flaky pain that often requires treating both the mother and the infant's oral thrush simultaneously. Internalizing these precise clinical features, from benign cysts all the way to the ominous dimpling of Cooper ligaments, gives you the rapid, targeted decision logic required to master these presentations and deliver flawless patient care on the wards.